On behalf of TechBharat team, a very warm welcome to the excellent panelists that we are presenting here today. The panel will be deliberating on the topic, technology for public health. Let me give a small overview, a small outline of the topic. Technology in the form of medicines, medical equipment, and diagnostic devices has long catered to the curative approach towards health. Public health, on the other hand, mostly looks into primary healthcare and preventive and promotive care, improving health-seeking behavior, prevention of diseases, and health system strengthening. Technology has always played an enabling role in public health, and it is increasingly assuming a central role in many public health interventions. Affordability, quality, wider reach, simplicity, and scalability are often used when technology solutions are built for global health and international development. Unfortunately, the adoption of technology in public health has not kept pace with the advancements in the fields. Cases of successful usage of technology in public health interventions are few and are not yet utilized in their full potential. In short, we should aim at bridging the gap between how different stakeholders understand technology, encourage collaborations, and work towards a common goal of leveraging technology to accelerate public health outcomes. To dive deep into these very topics, issues, we have put in an excellent panelist. Let me have the privilege to introduce each of them. Mr. Raghavendra Prasad, founder, Project Step 1. Mr. Manasij Mishra, CEO, Doc Online. Mr. Kiran Anandam Pillai, founder and CEO, Drishti Eye Care. And Mr. Rajat Garg, founder, My Upchar. A brief profile of Mr. Raghavendra Prasad. Mr. Prasad is founder, Project Step 1, a non-profit volunteer organization helping India fight COVID, providing free telemedicine access to COVID-affected citizens in India. He is an active angel investor and advisor for many startups. His primary interests are in technologies and business models which can help rural India better integrate with the rest of the Indian and global economy. He co-founded QuickWell, a pioneer in digital healthcare in India, which was acquired by Practo in 2015. Rags, as he is called passionately among his friends circle, has over 20 years of experience in software industry. A computer science graduate from MS Ramaiah Institute of Technology, Bangalore, Rags started his career as a programmer working on many mission-critical global products. He loves solving people's problems using technology and has spent most of his career doing that. He has a keen eye for spotting trends and new innovations to solve problems and has launched over a dozen global products and has over a dozen international patents in his name. Mr. Manasij Mishra, CEO of Doc Online. Let me introduce him. He's the managing director and CEO of Doc Online Health India Private Limited and an innovative chief executive who has transformed a number of businesses. In this role, he is responsible for delivering his vision to create a healthier India for everyone. He has experience in health services, health insurance, and banking with leading multinational companies. Over the last 4 years, Mr. Mishra has successfully scaled up We Health by Athena from a small startup to a rapidly growing organization with over 3 million members. We Health focuses on preventive and primary healthcare. As far as Mr. Kiran Anandam Pillai, he is the founder and CEO of Drishti Eye Care. Mr. Pillai, founder, is a social impact. Drishti is a social impact eye care chain delivering affordable eye care in underserved markets in Karnataka. Kiran, along with managing Drishti, is actively contributing as technology advisor at the National Health Authority on the National Digital Health Mission and Ayushman Bharat. His passion comes from the belief that setting up the right technology building blocks can help India leapfrog in how healthcare is delivered. Our next panel, Mr. Rajat Garg, founder myupchar.com. Before joining myupchar, Mr. Rajat has worked in Simply as a founder. He holds a master's degree in MS at Stanford University. MyUpchar.com is India's #1 health website solving healthcare awareness and access problem for Bharat. They cater to all healthcare needs of a family with high quality healthcare content, telecom consultations, medicines, and lab tests. MyUpchar.com's main mission is to vet health information available to everyone over the internet. I hand over the session to Mr. Raghavendra Prasad for the in-depth session. Please, sir.
Thank you, Shekhar. And I would once again like to welcome Kiran, Mansijay, and Rajat. I know all three of you are extremely passionate about making a dent in public health using technology. So it's certainly a pleasure to be discussing this topic with all of you. And I think we'll start off with just laying out how we all know that software is eating the world. This that famous essay by Mark Anderson, which actually predicted every industry will eventually be consumed by software. But what we who have been in healthcare for long enough also know that software is eating the world and healthcare is the last frontier. And healthcare is the last frontier because it is extremely complex. It is very regulated. It has various stakeholders, and more so within healthcare itself, public healthcare is probably the last. The last stone will be turned in public healthcare, and so it is extremely regulated. Public healthcare is very unique. We'll talk about why it is very unique, but the popular belief is public healthcare is very tough, and public healthcare will be actually the last within the last frontier, where software will eat the world. So without further ado, I would ask Manasij to come in and help us understand what are the key public health challenges in India, and throw some light upon what is the space that we are talking about within India.
Yeah, thank you so much, Rags, for that introduction and for this session. Yeah, I think from my point of view, one of the big problems in Indian healthcare is both the quality and the respect that we give to primary healthcare and to preventive healthcare. I think that's something that India struggles with. Unlike some countries where there's a very robust primary healthcare system, our systems are not available in the right quantity and not available in the right quality. And also, I think in urban India, certainly people who have money and who have access, there is no respect for primary healthcare. We tend to go to specialists directly. So I think this causes a huge problem. And I think it substantially increases the difficulty of diagnosis, substantially increases the cost of healthcare and the complexity of healthcare. So that's one big hypothesis that I have, is that if you look at the UK, for example, which has got, and if you compare their performance amongst the OECD, because of course these are all rich countries, and when the UK spends the least amount per capita and has the best health outcomes amongst the OECD countries. And my view is the reason is that they have extremely strict adherence to primary healthcare protocols. And even if you're willing to pay a lot of money, there is just no way that you can go and see a specialist without a letter of recommendation from your general practitioner. Uh, I think, of course, there is a lot of inequality, the urban-rural divide in terms of the willingness of doctors, nurses, paramedics to actually work deep into Bharat. I think that's a huge challenge. The fact is we are an out-of-pocket market. 70% of healthcare is paid out of pocket. Really, the government spending on public healthcare as a proportion of GDP has been falling and is quite low. So I think these are the other issues around healthcare. Um, and I think that sort of it's not just building hospitals. And I think sometimes people think that healthcare is about just building more public hospitals. And I don't think that's the solution to providing better healthcare. I think it's actually to have really well functioning primary healthcare centers. And there are some states in India where they work very well. But many of the states, particularly from the part of the country I come from, North India, Eastern India, the public primary healthcare system is not in very good shape, and I think that is a result of a huge amount of cost increase, inconvenience, disease burden, and I think that is where interventions, both technology led as well as other interventions, are really going to have a big impact on the health status of India. So that's sort of my hypothesis. I'm sort of biased towards primary healthcare, and you probably find that in my remarks as well.
Yeah, yeah. So let me now bring Rajat in. Rajat, what is you've taken a very different approach to public health and problems there, and you had some pretty good success so far. So what do you think are there other problems other than Manasij alluded to? What are the other problems that you see from your vantage point?
So, we started with um, content creation, trying to bridge the gap between the information awareness and the consumer. Because a lot of a big problem today in India in healthcare is the lack of awareness of consumer. And you have quacks telling them anything, and you take one lab report and go to five doctors, and in many cases in rural India, all five doctors will tell them five different diseases, five different issues, five different treatment methods. And it just depends on how much they are educated, how their incentive structures are set up. All kinds of stuff are there. We also spent some time going to villages and doing camps there, staying there and figuring out what the issues are and how can a tech company really help in that. We found that the challenges are actually fairly acute, and at some point, if people don't have a mobile phone access, smartphone access, tech companies cannot really help that without Bill Gates directly funneling his riches to a private company to spend on this. It remains a public undertaking. It will remain a public undertaking for a while because it's just too far below, and the problems are just too huge there. I think a bunch of issues. One, standardization of who is the healthcare provider. Um, I think that's one big part. The second is data collection. Uh, in terms of whatever prescriptions get written, they need to get recorded in some digital information base. Otherwise, they're not legal. Something like that. In some countries, I think in Thailand, they have Thailand or Vietnam, one of these countries, they have required everybody to submit a digital prescription. Um, all doctors to do that. So once you have a, uh bare minimum amount of data about the healthcare issues that are happening in a digital format, you can then tell people to, then monitor and guide the policy. Right now, what's happening is that everything is happening in vacuum. All the discussions are in vacuum. You don't know anything about what's happening in Aligarh in last 1 month. You sit in a Delhi office and make a policy about, or Lucknow office and make a policy about the entire state or the entire country, just without any details to the details of that particular issue. The third, I think, Asha workers is a very, very nice initiative by the government. Like they do bridge the gap, they do go to that ground level and make the connect. Although at the village level, people are not all village people are happy with their Asha workers, but at least there is a last mile connectivity there. So how do we basically uh, collect that information that they have. And um, l- private companies can leverage that information to provide more targeted care treatment plans. Can they be the point person that are delivering healthcare from a private vantage as well? Like, why just limited to the government side? So a lot of things can be done. I think uh, when we think about public healthcare and public issues, um, there is a lot of talk about GDP and number of doctors and this and that, and I do agree. We also make that same pitch. Ki, there is a 1 to 1300 doctor to patient ratio, but if you go to tier 2, tier 3, it's 1 is to 5,000. If you go to villages, it's 32,000 MBBS doctors in 5.5 lakh villages. So it's all broken. But when I look at efficiency, I think teleconsultation can bring that efficiency. So the 7 lakh doctors, whatever that number is, multiplied by 50 consultations a day, can do 3.5 crore, consultations every day. It's just that they need to be positioned properly. They need to be leveraged properly to be able to do those teleconsultations. So I think there are a lot of gaps in the efficiency. There's a lot of gap in the data collection. There's a lot of gap in resource utilization that's happening. And if we can just take one of these issues and just solve that, and then the next, I think we'll get there. The infrastructure is there. Again, as Masit said, we don't need more hospitals in these areas because the economics doesn't work out, right? So what you need is strengthening of the primary care clinic, um, and strengthening of these ASHA workers, and giving them tools so that they can leverage private, government, all kinds of facilities to do that. And the government will have to leverage private parties because government alone doesn't have cannot have that much of resources and focus to be able to do that. That's my thoughts.
Yeah, thanks, Rajat. So, Kiran, what are the uh, other problems in public health, and who do you think are the key stakeholders? I think Rajat identified a few stakeholders that private and government equally, and also use of ASHA workers and having data. I think you have a unique perspective of all this, both as a provider who has done extremely good work with Drishti Eye Care, as well as a technologist trying to help India have a digital framework and deliver digital health to these people. So, who are the key stakeholders, and what are the other problems that you think we should be looking at solving?
Sure. I think like to amplify most of the ideas that we just heard. So in my own work in trying to bring, I've not focused on primary care, but I've been really focusing on a single specialty. But even in that single specialty, what we should realize is, and you can break up that specialty, which is ophthalmology, into primary care, secondary care, and tertiary care. So you may not realize that almost 25% of the population actually requires glasses, right? And we recently we've been running a population level coverage program in one of the talukas where we are covering about 300,000 people. We have a door-to-door approach where we are screening everybody, and we are finding that 65% of the people we are identifying with problems, eye problems, are using glasses for the very first time in their lives. So tells you that there are many healthcare issues, including in this case, like the ophthalmic issues, where lack of access to care, lack of providers, lack of trained quality people who can actually go deliver that care is still going to be a problem. So one of the large problems, we cannot, while we want telemedicine and other technology approaches to solve it, I think the skill gap, the need to create skill workers, and the need to probably also do what's called as offloading. What work. So, for example, we don't talk much about the whole nurse practitioners. That's a huge thing in the UK, right? So, if you actually look at our healthcare trained staff, yes, we have a very large lack of doctors. And if you read any of the work that, say, Jishnu Das or others publish, you will know that the very first person point of contact for most people in Bharat is not actually a trained doctor. A very, very large portion of informal providers actually form the first line. And I think we aren't doing enough as a country to use or find alternate approaches that actually enable these people with better training or enable certain solutions where, if we just keep saying that we need to put more doctors on the front line, and you can just take a look at, how many MBBS people we are producing each year and how many are willing to go to the front line. But the reality is that there are a lot of other people who are willing to go to the front line. How exactly can we utilize them using a combination of policy, technology, training to actually make that shift in healthcare? I think is going to be a very key way to look at the problem, right? The second big issue is, this whole out-of-pocket payments that Manish was referring to. Most countries which have solved this well usually have some kind of a UHC, right? So there is this fundamental right to health as a construct, and the government will provision for saying that a certain basket of payments or a certain basket of treatments, medicines as well as treatments, you can be assured that, hey, you will get it for free or it will be covered, right? Now, the way it is delivered can vary, right? So the government in India can make a decision whether it wants to be a provider like it does today. So it can say, like the NHS, that I'm going to run everything from hospitals at the AIMS level to this little tiny health and wellness center in the front line. Or it can say, I want to be a payer and let me actually create an ecosystem which is a mix of public and private. And I think one of the things that I see when I work with the government is that we are still evolving on how much we are willing to say, okay, we are willing to let the private do. Is private providers are all private providers in healthcare in India profiteers who are just out there to make money and exploit people. And so that socialist approach that we still have, and that balance is being fought. So it was quite interesting that the government created the National Health Authority about in 2018 and actually made it a fairly large payer. I think it's not large enough. In many ways, there's a long way to go, but it's a start. And unfortunately, it doesn't cover primary care. It only covers secondary and tertiary care. So at this point, the current position of the government is that primary care we will still deliver using our, PHCs and now health and wellness centers. And it's not clear what would be the role of the private sector, if any. And there is, like Manish said, I've seen many startups who all believe that the private players, the NGO sectors can actually do a lot in delivering in the primary care sector. So I think it's an evolving space, and I think there will be pressures to evolve models, specifically models that go towards per capita payments that will help cover everything from primary to tertiary, right? So UHC usually, when you implement it at this level, you usually say, can I pay some provider X rupees for his family so that a whole basket of care from primary to tertiary can be covered by that. And so we haven't still seen that. So my own hope is that in the next couple of years, maybe there'll be pilots at least, and I hope that will be done with active public and private participation, right? The third area, I think, as we evolve, right? So India is many Indians in many ways, right? So we have probably some of the best surgeons. So when I look at my surgeon, one of my surgeons in one of my hospitals, and I can tell you that many of them have done far more surgeries than somebody in NHS UK, and they're probably far more skilled, and if you look at outcomes and if you look at even infection rates, our numbers are better than NHS UK. So India is not that India cannot deliver very high quality care, and it is definitely shown that it can do it. But India being many Indias, we have healthcare infrastructure of all sorts and types, from the very best probably in the world to something that's highly variable, and it is so fragmented, right? 95% of healthcare in India is provided by individual owners and providers, and this fragmentation makes for extremely hard problems, especially when it comes to data and digital data sharing. So Western markets evolved their health data sharing, their health data standards, mostly driven by payer push. It's the insurance companies that bet up all the providers saying, if you don't give me the data in this format, in this standard, I'm not going to pay, right? With a 70% out of pocket kind of a structure in India, how do you end with a fragmented care delivery model? India is actually very challenged on actually how do you solve the data problem. But as you rightly put, right, healthcare, while technology may be the last bastion for healthcare, I mean, I can also, you and me know that the most advances in use of AI in healthcare are actually happening, use of AI is actually happening in healthcare, specifically when it comes to, say, radiology reports, right? Imagine during the COVID period, X-rays and digital X-ray machines are really available down to the talukal. Could an AI that could have taken a chest X-ray and given you an early indication of COVID help, right? But that requires data, that requires training. How are we going to get access to this, bunch of X-rays which are labeled? How do we get it access to a startup ecosystem that can train? How do we put it back into the field? All of these are the technology problems which are actually quite unique and challenging. So the other part that's been very interesting for me on my personal journey has been the last 2 years, where we have kind of come up with a blueprint on how do you solve this problem for a fragmented nation like India, while dealing with all of the whole privacy and security that's going to be required, around it. Health is a very sensitive topic. The day somebody loses his job because his employer discovered that he has HIV from his health record, that's the day, everybody is going to really come down on any technology like a ton of things. It doesn't matter how good or bad the whole thing is. So creating something that's aligned with the personal data protection bill and having a model that can actually fit this fragmented care has been the second journey, so which I've been trying to go through with the National Digital Health Mission. So it's very early days, but happy to share more about how this is actually going to help and impact healthcare, including very much primary care, and hopefully, and we hope more importantly, the need of how it can be used to shift our behaviors towards preventive care, which is the only way I think we will all be able to afford whatever is going to be the overall cost of healthcare whenever UHC comes.
Thanks, Kiran. If I would like to bring Rajat back in, I think all of us have been, affected by pandemic, and definitely most people believe that healthcare has been one of the beneficiaries of the pandemic, so to say, especially the digital healthcare and the adoption of digital technologies. So, Rajat, what are the key changes that you see post pandemic, which have changed the way all stakeholders are in healthcare think about digital and adoption of digital technologies for delivery of healthcare?
Very interesting and very surprising, and thank God it happened. The change happened. So earlier, we as we work a lot in tier two, tier three towns, rural areas. So we spend some time with doctors, and we go with our app, and we'll see other people going with their apps and technology products, and doctors will be just shooing them away. Okay, yeah, ये सब नहीं चलता, हम तो, we'll just write it on paper, and then a lot of companies were there who were basically trying to digitize the prescription using ML and AI and all that. And we were like, it's not because the handwriting is bad. It's because it's written in a format that the chemist nearby can understand. So you cannot really decipher that unless you understand that math. Uh, but what happened and ultimately doctors are also daily wagers. So they wanted to make revenue, and they adopted technology. Their kids taught them technology and how to make WhatsApp call, how to give advice to patients. Something that they abhorred, they hated doing before. And on the other end, the patients who were always threatened or always under an impression that unless they go to a clinic and get a physical examination done, they got a prescription, they got a medicine recommendation, they bought that medicine, and they uh, became healthy. So now the patient is like, I can become healthy remotely. So why I need to go to the clinic? And if I go to the clinic, in any way, the doctor Sahab is going to tell me to do a lab test of 1400 rupees. So I got fixed without that lab test. So I saved more money as well as time. So both without having to actually visit the clinic. so I think that's the biggest change that has happened. So on our platform, we saw a big jump during March, April in terms of consultation. But post that May, June, July period, we saw another increase of 25% in consultation requests, and we were all expecting a big drop off after this peak COVID and as the clinics started to open. And I know in tier one, in some companies, it has still dropped, but not in our case. So in our case, the number actually increased because those patients who have access problem discovered that they can actually go online and get advice and get a cure. So we have, um, in a way, been benefited by this pandemic. Um, not not enough commercially, but at least the behavior has changed. And I feel that this is only going to accelerate as long as industry, health tech industry provides a good experience. So if people who are using Manas's app or my app get an A plus experience or Practo's A plus experience, then the trust in online consultation will increase, and then we can, of course, fight over discounts. But you know, uh, as to who will get that customer, but at least that trust will get built. Right now, that trust earlier that trust was not there. So I think that's the biggest change, positive change coming out of the pandemic.
Yeah, good. So, Kiran, a lot of pandemic certainly enabled on the government front a lot of things to change, right? We didn't even have a telemedicine guideline, and you were working for several years on your initiative. Finally, it got announced in a big way, and so many things have happened, in such a short period. So, I mean, how has it changed forever, or is it just we reacting to the pressures of the pandemic, or is there really a mind shift change and an acceptance that digital is very important for us to make universal healthcare happen?
Yeah, so I mean, I think there is a DNA shift for sure. So I'll give you the simplest one from a government perspective. Earlier, it was very, very difficult for me to do meetings sitting in Bangalore because the government most of the time was not electronic. And it's very rare today, to have a meeting in the government where there isn't a link shared saying, okay, you can join from anywhere, right? So that itself is a
Big leap.
indicator of it's a huge leap, for the bureaucracy, if you ask me. And so I am actually quite happy that that adoption, the fact that the acceleration of adoption definitely has been very real, and the pandemic has definitely forced a lot of it. And it's not just, I think, in terms of how they use technology, but it has accelerated this thought process. So, for example, exactly around the time that the vaccination program was coming in, the track to say that there has to be a software for the vaccination program also started. It didn't come as a later thought anymore.
Afterthought.
So it's an early this one. It's similar if you remember in the early days when the COVID and the lockdown period started. The technology for tracking, how many tests, what's happening, where is it, how do we define these containment zones, the whole Arogya Setu experiment, and so on. All have essentially really brought the need for technology up in the forefront, especially in the government. So it wasn't actually quite surprising that this blueprint, which actually originally was put out in 2018 by Niti Aayog called the National Health Stack, actually got a rapid stamp of approval and a push from right up from the Prime Minister's office, where the Honorable Prime Minister actually announced it on August 15th, that the whole National Digital Health Mission has been launched, and they actively track the progress of that in terms of how the integration with various players are happening. So I do believe that there is a very strong belief now, and one of the largest healthcare spends from a budgetary perspective also this year, there has been more impetus towards healthcare. And so I do believe that from a government perspective, there is now a very significant thought process and a view that IT in healthcare is going to have a big difference in how healthcare will be delivered in India. And so you do see very positive moves by the government in that space. Another instance that I would like to talk about, which is in telemedicine, which I'm sure both of these gentlemen have been tracking, is how the government is trying to do telemedicine using public hospital and public hospital doctors called e-Sanjeevani OPD. And I think they announced that they crossed about a crore of consultations or so online,
1
which is
million.
also a very good indicator of
1 million
adoption
was,
even
yeah.
in that sector.
Yeah, Manasij, I'll bring you in. Are you seeing this the pull in the rural side as well? Your unique perspective because of getting involved in Project Step One, as well as you're seeing both sides of the world with your corporate customers who are urban users who you would naturally expect, but you're also now you also work with the UP government and the EPHC projects, and do you see a behavior change on part of the consumers in both these spectrums as well because of the pandemic?
Yeah, no, I think the pandemic has been very interesting, and I agree with firstly the comments that Rajat made, which if he had not said, I would have said, is about saying that it's very important for telemedicine players to have provided, I mean, to provide quality,
Quality.
because when people try it for the first time, and if they get a quality experience, then they are sold onto the concept. And I think one of the big things, as Rajat mentioned, was that the trial or the frequency of new people trying telemedicine did go up a lot. We saw a very large increase ourselves in terms of the number of people trying out telemedicine. In our case as well, we have not seen a drop in volumes. In fact, our volumes have also gone up on the urban side after that. And I think that the customers will remain where they believe the service is fantastic. And I think that if they don't, and I think people who have had a good experience will continue to use telemedicine. Of course, my dream is a little bit more than that. It's that I don't want to be the doctor who is available when my doctor is not there. I want to be the patient's main family doctor. And I think that is some behavior that we would like to drive and like to change in the future. On the rural side, actually, it's quite interesting. I mean, I think that we started a pilot project with the UP government where we digitalized these, just a small number of primary healthcare centers. These were centers located in very remote parts of UP, had been shut for many years. I mean, most of them were like those bhoot banglas. They were like just abandoned government buildings with nothing. I mean, windows broken, absolutely nothing, no electricity, connection long discontinued. And then they handed these over to us. And we actually, in November of 2019, launched this service where this is an assisted telemedicine model. And I think this could be something that could be a way forward, particularly where people may not have access to technology or maybe unfamiliar with technology. So, that model, when we started, we were very scared that, the public will not accept it. And will they come to a primary healthcare center that had no doctor? And we were quite surprised that actually the adoption was really quick. I mean, on the one hand, in most of these centers, we were the only option, and the next available healthcare facility was like far away, and to that extent, these were people who were desperately poor, and their value of time is very high. When you are poor, more than us, I find that the poor people, for them, time is much more valuable because time means loss of wages. So I think there was a big sort of economic reason for to coming, but still we were surprised. And I think we were doing pretty high volumes in February when we were suddenly shut down due to the sort of pandemic and the lockdown being extended to the outpatient facilities. But we were seeing about 500-600 people in our 10 centers coming in and getting themselves treated. And I think that once we reopened, it took time again for the volumes to go up. But every day now we are finding that volumes are going up a little by little. Every day there's a step up in the volume of patients that are coming. So certainly the urban poor, and because we are also having two urban, so two of these PHCs are in urban India, urban poor in UP and rural poor. Both sets of people have adopted to this idea that they will go to a primary healthcare center where there is no doctor. There is an A&M to help them. There is a point of care pathology, and there is point of care medicine delivery, but there is no doctor. And they seem to have adopted to it very well. And I think we've been treating a lot of people every day. But this was not linked to the pandemic. This is just, I think, the fact that this primary health center restarted. It had a coat of paint, and then suddenly there was some activity meant that the traffic started coming in from the nearby villages. So there, I don't think the pandemic has played any role, because in any case we were closed during the worst of the pandemic. Our volumes came down to zero and now have started to go up once again. I think it just goes to show that if your service is adding value to the consumer will adopt any technology. And I think healthcare is no different in that way. I mean, my favorite example is, of course, I used to be in the banking e-commerce team in HSBC in 2000, the first dot-com boom. And we got a panic-stricken message from Hong Kong saying there is some rogue website which has been set up in India because their utilization of credit cards is actually more than anybody else in the world. And can you please, since you're based in India, give us a little more information? It is called Indian Railway Catering something. And we don't understand this. Why a railway catering website would be attracting so much of credit card payments. And, it was way back in 2000, but you had the technology. And in those days, the tickets were not electronic. The tickets used to be sent by
Postal.
messenger,
Right.
the postal, to the passengers' homes. But still, the experience was so beautiful that it became the world's largest e-commerce website overnight. And there was a lot of panic and risk management going on, saying, who are these people? What's going on? And then we had to sort of write a long paper about why it's all okay. But that's it. This is very similar. That if you have a service that provides something that you need, you will overcome the technology barrier very quickly. And I think the fact that right from November 19, where COVID was not there at all, people started using this primary healthcare center with no doctor. And it did never ever seem to be an issue that the doctor was not there. Some of the patients were quite keen to look at the doctor. That's an interesting one, because when we started first, some of the ANMs used to look at the doctor and only turn the camera towards the patient. But that we quickly learned wasn't a very good experience, and the patients wanted to see the doctor, so we had to flip the screen around. So yeah, they want to see the doctor, but they don't need to see the doctor in person. So I think, to summarize, yeah, on the urban side, a lot of trial, and to the extent to which that trial will remain and people will remain loyal depends on the quality of the service. And it's very important that people like us and Rajat and other people, and that we keep that quality at the center of what we do. But I believe that if you have a compelling healthcare service, the UP government, incidentally, has recently issued a press release saying this pilot is a success, and they're now planning to scale up to 100 centers next year. And I think this is an interesting model, and this is a very, very good way of solving some of the issues in rural healthcare. And that's sort of
Excellent.
not linked to the pandemic, but it's around the same time.
Right, right. Good, good. So, Kiran, I'll bring you in, and there is when we talk about technology for public health, there is so many technologies, right? And there are so many approaches. What are the most important ones, and what are the ones that are kind of upcoming? We have a plethora of devices. We have chatbots. We have of course content and various tools for delivering content. What are the how does one navigate the technology landscape, and what are since you are also involved in so much of standardization efforts, how do you account for so much of technology which has potentially not even been created to address this problem?
So, I mean, I won't be able to specifically because I'm not the expert on many of these pieces, right? So, what I'll tell you is instead how the National Digital Health Mission actually visualizes this uniformity. How does it see this plethora? How does it see Mayupachar and Manijay startup actually contributing into this overall? I think that's a much easier construct to understand. See, I
Sure.
think let's start with the fact that healthcare providers today are actually trying to share health information with you digitally. I got a COVID test, and most of us probably might have experienced a COVID test. Most of us probably got an SMS on the phone, at the post the test, and we probably went to the lab provider's website, put some code in, and then we could see a PDF of your COVID report, right? So what's really happening here is, a lab report is being shared with the patient digitally. And in a healthcare construct, we think, and I think specifically, that this phenomena of sharing health information with the patient digitally is going to continue to grow. And a lot of lab information management systems, hospital information management systems, or any software, or even telemedicine software that we see today, all do this. Now, the problem with the approach is today it's completely custom, right? That report that I got and I saw is not part of my history. I'm likely to lose it in about 6 months from now. It didn't really become part of anything that is useful. Two, it was a PDF, probably not machine interpretable so easily, right? So the National Digital Health Mission only tries to solve these two problems at this stage. It's a very simple idea. It says, hey, if you want to share a health information with your patient, please link it with something called the patient's health ID. So anybody, all of us can go get a health ID. It's very easy. There's a site called healthid.ndhm.gov.in. There's going to be multiple providers issuing health IDs, but even hospitals can issue health IDs, telemedicine providers can issue health IDs. So, but idea is get yourself a health ID. It's similar to a UPI ID. For me, my ID looks like Kiran MA at NDHM right now. And what the protocol allows is it allows for any validated provider. So this is the second important thing. So it's not that anybody can add a health record into my health ID. You need to be a registered provider. And so there's something called the health facility registry where you need to be a part of it. But fundamentally, if you are a registered healthcare provider, you will be able to take your health record and link it. So in a link, all you're saying is, I have a health record for Rags or for Kiran in my hospital's software, right? That's all you're saying. Now, the second thing that NDHM says is that, look, you can receive a request for that piece of health information that you have. And if it comes along with Kiran's consent, please release it. So it says share that with Kiran's consent. And two, when you do share it, hey, see if you can make it a machine readable format rather than an attachment, right? Though you can start with an attachment under the current rules of NDHM, in about a couple of years, we expect you to actually do structured data. And for that, it uses a standard called FHIR, which is fast health interoperability resources. Pretty easy. And so we have standardized just 5 types of documents right now, right? So you can do diagnostic reports, both pathology as well as X-rays and MRIs and CT scans. You can do discharge summaries. You can do prescriptions. You can do OP consultation notes, and you can do immunization records. And that's it. So and these are things that are commonly shared with patients. So we're saying share this digitally. And if you look at this experience, so all we expect is Rajat's software to become NDHM compliant. NDHM compliant means Rajat comes in, there's something called the sandbox. It's a place where we have hosted all these APIs. Rajat's tech teams will integrate with these APIs and make sure that whenever after a telemedicine consultation, they want to issue a prescription, they actually issue it in an NDHM standard format and they link it with the health ID. So they collect the health ID. Now, here's the other interesting part for telemedicine providers. If as and when this health ID and the linking of records by different providers starts to happen, anybody with a health ID can share their health information with anybody else with consent. So in a teleconsultation call, you start the call, you have a patient on the other side, you can send them a request saying, a consent request saying, I would like your last 1 year's medical history. On my phone, there'll be a pop-up which says, my upachar is asking for your last 1 year's history. And I can look at it and I can say, okay, I'm willing to give everything, but this is a diabetes consultation. Should I give them my mental health records? Maybe no. So you decide what to give, how long to give, and then based on your consent, all the associated records that were linked with your health ID, a copy can go to my upachar. So it can pop up right in front of your doctor's screen so that they can look at your history. And now anything that they are doing, which is adding a prescription, prescribing a text, they can again add back into your overall longitudinal record. So that's the big idea. So the big idea is a small bunch of what we call as digital building blocks. So these digital building blocks in this case are the health ID and the consent manager, which I spoke about, and the health facility registry. These are the three building blocks that we described in this flow. And it's open to any software, any provider in the ecosystem to kind of integrate. So happy to share with you now. The idea is simple. How does it actually, become part of our lives? So we are working with three large groups to make it a reality, right? Group number one is the government. So in the next 2 years, so already integrations are done with software providers to the large public hospitals. So, most big hospitals like AIMS or district hospitals all use software, usually from NIC or from CDAC or some of these other large providers. So these are already done. And so you should expect that every public health program and every government hospital which is using any software to start adding records and issuing health IDs. So public health programs, let's take an example of the mother and child program, right? The mother and child program is one of the largest programs from the government, and it touches, for example, it holds immunization records for 100 million children. It holds antenatal records for over 130 million women. So these are going to become part of it. So today the government doesn't share that with the patient. Now we are saying, hey, even if you're a government service and you have a piece of information, share it. The NCD program, which is doing door-to-door screening and is checking for 5 different health conditions. It's checking whether you're diabetic, you're hypertensive, whether you have oral cancer, breast cancer, and so on, is also going to add health information to your primary care. So if you were to visit, I'm hoping if Rajat, for example, in the PHC that is doing in UP, when he is issuing the prescription or when he is issuing an OP consultation note, I hope he can create a health ID and add it to the patient's health record, right? So that is the only way you will get portability. When the person goes to the district hospital, you can actually pull the record and see what happened. So for us, the core idea is that the data belongs to the patient. The data should be movable with the patient and it should be accessible to anyone with consent. Now, who can access the data? We have no restrictions. You could be a mobile app that says, I want access to the content, right? So we visualize a future where there will be diabetic apps, which will actually pull your data and then give you better advice on how to manage diabetes, right? Probably there'll be an oncology app and says, oh, you're a breast cancer patient here, let me tell you what's happening based on your data. So it could be an app, it could be an insurer, it could be in the context of a claim that you have. There may be certain restrictions about you using the data in the context of individual premiums, but that's evolving regulation, but it is available to insurers, right? It's definitely available to doctors and so on. So this idea that even in a fragmented world like ours, in India and the way care is delivered, that we can actually bring data together and make it very powerful for everyone is the core idea of the National Digital Health Mission. So apart from cohort 1, which is the public health systems, the second large cohort we're working with is what we call as organized corporate healthcare providers. So imagine the Apollos, the Narayana Healths, the Dr. Lal Path Labs. So happy to tell you that most of them have almost at the late stage of the integration. And the last set of players that we want to work with is anybody making a software for a hospital or a lab. So, QuickWell would have been a target probably in my previous, in your previous avatar, but fundamentally people like Practo.
Well, still probably will. It's still being
Yeah.
used, so the software
So
can.
anybody in that, and telemedicine players for sure, because it makes sense to a lot of these people. So, but that's really how we kind of look at it. I would just, since you asked me this other question, I was part of a advisory to the government on the technology initiatives for health and wellness centers, and so one of the recommendations that we made was based on an idea that was very similar to what happened in our experience with Aadhaar. So when Aadhaar as a program started in this country, there were no standards for biometrics. So the little device, that biometric device, and the output of the device was not standardized. So which every vendor would say, you not only have to buy my device, but you have to get my software, right? So what Aadhaar did was it said, hey, you want to work with the Aadhaar ecosystem, your biometric device needs to produce an output in a certain format. I don't care, who makes the device. And so that is how we actually changed how the price of the device actually evolved in the market. Because you created an ecosystem where there was a need for devices, and then it came. So even in the health and wellness centers, it is very clear that there is going to be a plethora of devices that are going to become available, right? So there is lots of innovation happening there. And the question really is, how do large players, like for example, the government is very clearly announced that it will set up 150,000 health and wellness centers. And it is saying that, yes, I am going to have all kinds of diagnostic devices here. That is not a small market by any, metric. And question is, how do we make it a viable market, an interesting market for a large number of players? So our recommendation was that the government should start by standardizing actually what inputs it requires rather than the actual device in the device specification, right? That's
Makes
advice
sense.
number one that we are giving, right? So, hey, you want to collect an ECG? Okay, what is the output format of the ECG that you want? You want to collect a BP from a device? How do you want it, right? And what interfaces should it support? Whether it's a USB, Bluetooth, whatever it is that you want to have. Make sure that you publish these standards and say, all health and wellness software guys, this is the frontline standards, right? Two, should you be only doing a procurement based model, right? Should you be buying and saying, I have a capital investment in a device? Or are there more interesting models where you can say, hey, I'll pay per acquisition or I'll pay per use, right? And if it's not working, I know from the data that it's not working, so I won't pay, right? So I think in terms of how models could come that could actually make a huge shift for primary care players in telemedicine, otherwise, I think the government can actually be a fascinating catalyst.
Yeah.
Take a couple of these ideas and say, how can it actually help create these things? So that's really some of the things that I push for sometimes in the government. Some things
Sure.
hopefully we'll see some action, and so hopefully that will create certain opportunities in how the market evolves. But at least those are my views on how technology can actually make a difference as we
Sure.
go forward. And I think we're at a very, very interesting junction or a point
Yeah.
that in India.
Yeah, so I think, yeah, the standards for data interchange, standards for devices, I think is very, very critical. But in terms of other base technology, which is very important for digital health to take off, how does 5G score, Rajat? I mean, what are the other technologies which really are extremely important for us to, see see universal health being delivered via digital platforms?
Um, see, bandwidth, of course, is a huge constraint. Um, Remote diagnostics is the second big issue. When you think of bandwidth, right? So we had a video consultation app, like people can opt for video, and very quickly we realized that in most cases you are unable to talk on video,
Yeah.
even after geo. So what we did was we basically changed it to you record your video and then upload. Like every village has a Bargat ka ped where they go and then the connection is better and you can upload the video. So unfortunately, that's still the case. Although it's improving every 6 months, it's improving, but it's still the case in quite a lot of places. So bandwidth needs to improve. I think a lot of work is getting done. Geo is doing a lot of work. Airtel is doing a lot of work. Government is doing a lot of work. So hopefully that will become a issue of the past, but it's still an issue. And products like ours, we had to adapt to the current situation on the ground. The second thing is around the, uh, what I was going to say. I completely missed the point. I'll just recollect it and come back on it.
Yeah, so basically, other technologies which are critical for fast adoption.
Yeah, sorry, remote diagnostic.
Right.
That's the big missing piece. So in teleconsultation, the biggest issue we see is the that we don't have any vitals, any information about that particular patient, at least for in that particular price. So if you have remote diagnostics, even if it's a BP instrument or a sugar measurement instrument, and the ANM or whoever is carrying that, then you can actually get a lot of data about that particular user. Also, as Kiran was talking about NHDM and the history, patient history. So over time, ultimately, we all have to integrate into it because the key missing piece in the third key missing piece is the patient history, that we don't have any idea about who that patient is unless we have built all that data in our own product. So of course, we are seeing some behaviors with a fraction, with few percentage of our user group where we have become their family doctor. So we know enough about that patient to tell them कि यार आपने पिछली बार ये लिया था, आपको ये होता है, so let's do this. But that's not the majority use case right now. So I think those are three big areas that I think need to be addressed. The last two, um, in all the areas, there's work that's happening. Hopefully, 6 months down the line, these will be a non-issue. NHDM gets adopted across the board. Internet connection is better, and remote diagnostics are in hand of everyone, and we are going to be doing this now. But yeah, since Kiran, you are here and you're talking about this, why don't you also look? One piece of input is looking into getting doctors to write prescriptions on digital input tools. I know it's a hard thing to do, but that is one thing that can really improve the overall data quality that we have.
If I can jump in on that project, so I think it's a great topic, and at least let me lay out how we are thinking about this problem. So I think, India, like I said, when I talk about many Indias, right? So there is an India that is digitized, and I think Rags can talk about how many single primary practitioners or clinicians who use, say, some of Practory or others actually do digital prescriptions and OP consultation notes today. It's not that the practice is not there. It's just that the segment or number of people doing it today are very tiny, right? And I think we need to separate the problem of digitization from the problem of sharing data
Sharing.
digitally and being, doing it with standards and consent. So NDHM's focus today is actually to make sure that anything that is already digital first becomes useful to the ecosystem by people participating by sharing in the data as well as making it standardized, because that's the core aim. And I do believe that the digitization, like, there are two or three ideas. If you believe Mark Anderson and the fact that the software is eating the world, I think 10 years down, right? So 10 years back, I would have argued that none of us believed that, and I have run telemedicine clinics in tiny villages about 12 years back, and I can tell you the only way I could do it was I had to put point-to-point microwave towers to get the bandwidth I wanted for the video call, right? So 2G was the kind of the norm for my village side, and I couldn't believe. But today I go to the same village, 4G is running with pretty good video. So I think, while I do believe that digitization is a trend that cannot be stopped. It's this one that's coming, and I think it's question of time, and I do believe that it's going to take. So specific to the prescription problem, so if you look at what is digitized, diagnostic reports are the lowest hanging fruit. There's a large percentage that's digitized. Discharge summaries to some extent. Prescriptions and OP consultation notes are the worst. They're the lowest one. So there have been a couple of ideas that have been floating around as to what is the trigger point or the incentive that will trigger, digital prescriptions. So one big idea has been, imagine if there was a certain category of medicines which were very common and for chronic conditions that the government could give for free if you could get a digital prescription from someone. And this is a big idea. And you could imagine if you could actually collect it from any medical store as long as you gave a digital prescription, right? So there are a few ideas that are floating around on what may actually be the large incentive that creates that market. The other thing that people are talking about from the insurance industry is if OPD insurance comes in, right? Because OPD insurance is not going to pay unless the doctor is actually going to issue a digital prescription. So I think there needs to be drivers that trigger what that behavior change in the doctor. But without those drivers, I don't think you're going to see the shift to digital prescription so easily, especially from the current set of practitioners. The other thing I see even in my own hospitals is younger doctors who are coming in today are more comfortable working with and creating OP consultation notes completely on a computer, as opposed to my older doctors who still prefer the pen and paper. So it's also maybe just a generation thing in terms of how this may get adopted.
Right. Also, there are many technologies which are helping, the older generation adopt. I think there are digital pens. There are a couple of very promising startups which certainly have made a dent already in the number of prescriptions and in OP being digitized. Yeah, it's growing pretty fast. But one important thing which Rajat, I want you to weigh in is the vernacular language. You've seen most of your customers are vernacular language customers, and that also brings a lot of challenges because in India the standardization of uh, the vernacular languages on the digital front is still there are still many gaps. Though a lot of work has been done. Most startups shy away from that. You're taken on that problem, so because of the gaps. So maybe you can throw some light on that also, because that's also a technology and standardization problem, right?
Multiple challenges. We have done a number of things on that part, but there's still a lot of challenges. So if
Right.
people choose NEFT, then they go to a bank site, and suddenly that's an. So we used to use a standard payment gateway, then we realized that it's not in multilingual. So we built the entire uh, interface on our end and just use the APIs on the back end. But ultimately, they have to be redirected at some point to bank or some other site. So there are some challenges there. You work with courier partners; they don't accept UTF-8. So if the person actually writes the name in Hindi, the airway bill generation APIs typically fail. So then our team will write the name in English or use a translate to Google Translate or something to generate it in English and then send it back to them. So lots of small issues like that. But I think when I think about 4 years back about acceptance of companies like us was like when we went to market first time raising our angel fund, people like who are these people? ये कौन है? And nobody and even yesterday I was interviewing someone for product management, and I said, tell me what is the population estimate as population that lives in tier 1, tier 2, tier 3 and tier 4, and the answer was 600 million people live in tier 1. And how many villages exist in India? Three villages per tier 1 city. I'm like, again, Delhi se bahar hi nahi nikle hain log. I've never stepped out of Delhi, so it's a bit of a challenge, I think, on multiple fronts. So people, you are raising investment from, they have not, most of them have not traveled to these parts, so they don't realize who that customer is. When you are hiring for product management or content or any of that, there is a certain level of bias in the content writing as well, even if it's a medical content writing. To think, not think about the audience who is going to read it, right? So if you get a top-notch doctor to write it, he's not thinking about that consumer, and you literally have to break down that content into that particular language. And then you're looking at technology, fulfillment, consultation. Most of the doctors, if you go in Delhi and you say, "Yeah, we want you to service the tier 2, tier 3 users," they immediately think the maid that lives in their house. And we're like, there are a lot of educated people in those parts of the country. It's not the maid of your house. And they're like, that is social work. I'm like, no, we are going to pay you for on a per consultation basis. It's not social work. We are trying to make a business out of it. Yes, there is a certain segment which is where it's social work, but there are certain payable people who are ready to pay as well. So it's just awareness about this particular customer, and the fact that they can pay as well, because most of the companies have kind of shied away because it is hard,
It's
but
hard.
they are ready to pay because they need services and they are aspirational. And in certain pockets, and maybe it's a 80-20 rule, so you have to find the 20% who are going to make that 80% of the payment, but there are people who are ready to pay for services.
Manasij, I'll now bring you in, and will India, like just like India leapfrog the wired telecom and went directly to wireless and wireless data, and we almost leapfrogged over the PC era and went directly into the smartphone era, right? Will is there a is that something looking to happen in India? Are we going to leapfrog, and will our universal healthcare delivery be primarily digital? Will you think what are the key models you think should will that will enable it to happen, or what are the key models you expect to emerge? Kiran actually talked about one interesting model of subsidizing or giving medicines for free for digital. What will be the enabling models which will actually make adoption explode?
Yeah, so it's a very fascinating area, and I think that Kiran was saying that India is living simultaneously in many centuries, and I think this is so true,
Yeah.
and to some extent, I think the future is already here, and there are enough pilot projects being run by different state governments on the primary healthcare side. And my own view is that in the days to come, and it could be within the next 5 years, that a vast majority of the rural doctor problems will get resolved because there will be no, people say that the big issue is doctors don't like being posted to rural India. My
Rural.
answer is, why post them? Why do you want to post them to a place where your absenteeism is going to be 80% or 50% or 40%, right? Why even bother? Because technology, you don't have to be very high tech, and that's the other thing. I'm not an engineer, I'm not a doctor, so somewhere I'm sort of a confused sort of soul, with no bias towards high tech and no bias towards fancy medicine. But if you look at it, I don't think it's about. So most of our consultations happen on a phone, and we do a lot of work in rural India through some of our partners and some insurance companies and so on, where we have large rural populations that we are handling. And there is nothing wrong with a candy bar phone, and you can provide and we send out prescriptions through SMSs. We have a detailed consultation on the phone. So I think technology is not the problem. I think the issue is that, like for example, our UP EPHC, there's no reason why that 100 should not become 10,000 or 15,000 EPHCs. So wherever you are outside the main centers, or a category of primary healthcare centers never has a doctor. And the government works on the basis that these will not have a doctor, and they will get into a business model with a private sector player like ourselves, like Rajat's company, or like many other companies who can provide that back end support or that front end support to ensure that this kind of manned telemedicine model, which is some people like calling
Assisted.
it digital model, right? Which is physical plus digital, awkward word.
Digital.
So I think those sort of models are here. They're here already, and they're being tried all over the country. It's not just in UP. I mean, there are many state governments who are talking about it. Many of them have already implemented it. Some for specialists, some for primary care. So I actually think that in the next 5 years, we will stop talking about posting doctors and nurses to villages. It's not something that will be required. A vast majority of these primary healthcare centers will be operated on a phygital or assisted telemedicine type of model. I think that the pandemic has shown the government, and obviously your initiative, step one also was a big one in terms of changing the mindset. And Kiran also mentioned he gets a link now saying you can join a government meeting electronically. It's a mindset shift which has happened. And I think that mindset shift is also happening with regard to the involvement of private sector players in enabling some of these models to work. So these models are already here. The future is here. The question is that scaling it up, having the right private public mindset and that partnership mindset to bring it all together and to monitor. People talk about the NHS, and I find that very odd. The NHS does not employ, the government in the UK does not employ a single doctor who delivers care. Nobody in the NHS. NHS is a contracting body. They don't have gazetted officers and people on permanent salaries and pensions who are running their primary healthcare service. No, they are all individual contractors, or at best, a group of 5 or 6 clinicians who have formed a little company. And they are being contracted by the National Health Service. And I think this is, Kiran alluded to it, and I think this is a big issue. The government of India has to make up its mind. Is it a payer? Is it a provider? And if it remains confused, progress will not be made. And I think he talked about the fact that now with the single payer is starting to happen. So I think we need to sort some of these political, intellectual, I don't know whether they are sort of
Model, I would say, the fundamental model.
Fundamental models thinking. The technology is here already. The business models are here already, at least in the primary care space. I think this people with a smartphone, I mean, you can build n number of point of care diagnostics on your smartphone. You can have a small device that makes it a blood sugar monitor. You can have a small device that makes it an ECG machine. You can have a small device that actually gives you very high quality images. So you can do a hell of a lot of stuff with technology. So I don't think the problem is technology. It's just getting this whole ecosystem to have faith in each other and to trust each other, and to come together and scale up the existing pilots. So I actually think in the next sort of 4 or 5 years, we're going to see this trend where high quality primary healthcare will be available in the remotest villages through these models, assisted telemedicine models. I also see that the work that is happening on health records and the National Digital Health Mission, the government projects do take time, but we know from Aadhaar, we know from having digital share certificates, we know from unified payment interface that ultimately India has shown the ability to implement very sophisticated, very complicated technology. Yes, it takes time, and it's not perfect on day one. So I actually think all this will come together. So we will have the digital health records. We will have public-private partnership. We will have the government making up its mind whether it's a payer or provider, and then accordingly setting up the processes and the systems and the technologies and the techniques by which they can contract in a fair and equitable manner. I think there are there's enough positive news around in this area.
Good. Yeah. So Kiran, the is the A&M, which or the ASHA workers, them using them as a model or enhancing their skills with more tech. Right now most states use them basically as midwives, and they don't have enough technologies, tech enabling them a good model for and the assisted uh, PHC or the EPHC, which potentially is mobile because now the A&M is having a bunch of devices and digital software in on their smartphone. Is that the model? Is that the way to go, or are there other models which will help push the adoption in this area?
So see, as far as frontline health workers like ANMs and ASHAs are concerned, the policies of making them digital. So that every ANM should have a tablet, I think, is now 3 years old. It depends on where the state is in implementation, right? You go to Gujarat, in fact, you'll find that every ASHA worker has a
Even
mobile
Chhattisgarh,
device. Huh?
Karnataka as well. Karnataka and Chhattisgarh as well.
So depends on where the state is.
Right.
And so increasingly, for sure, there is a very strong belief within government that frontline workers should be armed with technology, whether it's a tablet or it's a smartphone, and the apps that will help them do their job better, are all coming. I don't know if you're aware, but for example, with the Vadvani Institute has a little AI pilot going where they can point it to a baby and they can get many parameters from head circumference, weight, and so on to help monitoring of children. This is not just a thing that you see in health. There has been a great initiative called CAS that has been towards Anganwadi workers, which is mostly also health and health parameter kind of a thing related. So I think uh, technology in the hands of frontline workers to help them make a difference in how they deliver healthcare, I think, as a construct from the government perspective is given. Now, effectiveness of that, there is going to be a bunch of random control pilots in terms of, what. So, because that's where the innovation also lies. The fact that now you can create an app you can actually push it out to say a certain cohort. You can then look at the results and then say, okay, what to scale up. I think that's the interesting part that's really happening. It's harder in government because governments usually don't think about these problems of saying, look, we want to have many attempts or many different opportunities for people. So, but that's some of the things that we typically tend to advise on when we deal with the government is find opportunities, because there is indeed a whole bunch of startups very interested in solving these problems or creating innovations in different parts of this overall ecosystem. So the bridge, and frontline workers are getting devices, and these are all mostly Android devices. It's not difficult, but how do you find this way to bring some of these innovations, bring them on, have say randomized control trials, then look at which ones you should scale up and so on. So those are the policy regulatory kind of challenges that I think government faces much more than just the procurement of the device.
Yeah, proving
In
those models, I think, is going to take time. Yeah.
yeah. So, but I think we should all expect that most of the frontline workers will have a device, and we should be designing systems with the understanding of how those work and how it can actually help them deliver better care.
Right. Rajat, what would be your asks? How do you think startups like yours or Doc Online, Mansit startup, how do you think you can work along with the government model? How do you think the a model can be created so that innovation in this area gets a boost, and you also get access to some of these government resources which right now potentially are being underutilized in this area?
So for us, two very clear-cut things could be that we have um, like the biggest repository of health content in Indian languages in world. Like literally, nobody else has it. Even 1/10 of what we have, and the quality is of course unparalleled. We love to share that content with ANMs and others who can then forward it to patients and make them more informed about their choices, right? So, because I think an informed customer is always going to be better than an uninformed one. The second is, we have seen government making attempts with Sanjeevni and other portals, and unfortunately, uh, the service quality, although it's a nice effort, the service quality has been a bit leaves a bit too much to ask for, and primarily because the incentives of a government doctor is not really that aligned, and there's very long wait time in terms of getting a
Yeah.
response and all that. So there are a lot of challenges there. We'll love to work with the government to figure out a solution. I'm pretty sure there are other teleconsultation players who will also love to jump in. As to how that can be designed better, because we've spent quite a lot of time trying to figure out how to make the connects quick and get to a solution quick, versus making people wait for like 6 hours to get to an answer. There could be exceptions, but that can't be the rule. So those are couple of like really high level direct things that we can think of. Of course, on the medicine side, we we basically ask our doctors to write prescriptions on a salt level. So we have a pretty clear idea of what is being written. We have reverse mapped every medicine that is that we could get a hand on, and reverse mapped it to the salt that it contains. So we have a pretty deep data set there. So any prescription gets written, we can map it to the salt level, convert it to that level, and then provide it. So it can help with the fulfillment side as well, because if doctor's writing some medicine, it's not there, then the patient will know कि salt है, उसके base पे क्या ले सकते हैं. And we can connect with the local chemist as well. So we have built a technology where the local chemist will get the prescription based on the pin code to fulfill. So if they become part of the network, because shipping the medicine from a central warehouse or from seller doesn't make sense in case of acute. So we can enable those connects, those deeper plays that will actually make teleconsultation very outcome driven, health outcome driven. There's a lot of knowledge in gained in the experiments we have done. We love to share with the government. We love to make their services better or work on models that can help both the sides.
Thanks. So we're kind of running out of time, so we will some. It's time for some predictions. Kiran will go first with you because you are the one who's driving a lot of the digital health and the other things which are very futuristic. So, what are your predictions for how public health in India will be in 2025, specifically the use of technology and how it's going to impact the delivery of public health?
So by 2025, so I'm making like a couple of bold predictions out on this. So my
Sure.
prediction is that by 2025, I think at least I expect over 300 million people to have experienced health ID and digital health records. So that's a reasonable chunk of the population, I hope, and maybe it's faster than that to hit that kind of a number. That's number one. And number two, I think in terms of how care is delivered, I think how if you look at the size of the teleconsultation market and how people are using digital for teleconsultation, I think it should be a significant, reasonably significant portion of primary care, a mix of both assisted and non-assisted, because that date also coincides by when the government is supposed to have operationalized a lot of the health and wellness centers. And we didn't talk about it much, but health and wellness centers don't have, many of them don't have doctors. They just have
Doctors.
yeah. So, and the only way prescription can be given there is with the teleconsultation. So let's hope that we do see both of that in the near term.
Sure. Over to you, Manisaj. What are your predictions for 2025?
One, I think we will see widespread use of telemedicine in the primary healthcare space. I think on the rural side, we will see a lot of assisted models that will really overtake the sort of man the doctor model. I'm hoping to see much better trust in the public-private partnership. Sometimes we work with the government a little bit, and sometimes it feels that we are criminals, and
Right.
they tend to come with that mindset with a whole lot of penalties, and they don't see the sort of big picture. So I think the public-private partnership needs to evolve to a level where there is more trust and there is more understanding of each other, rather than just being an adversarial relationship as one does feel on occasion.
Right now. Yeah.
And I think the health records, I know with Kiran and other people working there, I think we will see, particularly as an ex-insurance person, I would love to get digital records in the discharge summary. I think one of the biggest nightmares of health insurance is that the quality of stuff that comes in from the hospital network is just appalling, and
Right.
there is no diagnosis mentioned, there is no disease coding, there is no procedure coding, and I would, as a former health insurance professional, I would be absolutely delighted to see some of that happen. And the insurance companies, even, and regulation does not allow them to do individual pricing, which I think is very good and very fair. But at least at a portfolio level, they can start to analyze the kind of health risks they are carrying. Today, health insurance is pretty much a shot in the dark.
Right. Rajat, over to you. What are your predictions?
Uh,
Yeah.
Quick ones. I think telemedicine is a given. We feel that there are a lot of inefficient players in the ecosystem, whether it's small clinics, small hospitals, individual doctor setups. Um, I think a lot of them will face pressure in terms of trying to maintain their livelihood. They'll get consolidated into corporate hospitals and corporate chains. You will see a lot of that corporatized so that so quality of care will improve across the board. On the pharma side, I feel because of teleconsultation, you will have a lot of data, and the pharma companies will provide more precision medicine option. Right now, there are like bot even when you know the weight of the patient, you're still giving one variation of medicine, and you can get to more accurate dosages and all that. So there is just a, I think it's a huge disruption that's coming in next few years. A lot of MRs are going to lose jobs. A lot of so you will have to think about reskilling a lot of these people for new types of jobs in newer economy. It just is a there's a there's a lot of change coming with the teleconsultation and tech incentive piece. But the model is going to be efficient, newer job opportunities. Older people will have to reskill themselves to do that.
Thanks, Rajat. And I think we had a excellent perspective from three people who I know have worked very passionately over several years for in the healthcare space, and now will have a huge contribution into in the next few years, certainly, and hopefully many more years beyond that in shaping the public health infrastructure and use of technology specifically, and coming up with models in the upcoming years. So thanks a lot, all of you, for throwing your perspective. It's very clear that technology is here to stay, and here to is the only hope probably we have to providing universal healthcare in our country. Thank you. I really enjoyed the conversation and the ideas that were generated here. And hopefully, in the next few years, we'll see all of them, all the new ideas come to light, and we'll all grow the overall uh, public health, technology in public health. Thanks.
Thanks, Rax. Very nicely
Thank you for
moderated.
having us.
Thank you.
Really thankful to you, Mr. Raghavendra Prasad, for anchoring this session. It was indeed a very, very comprehensive and in-depth session. My special thanks to your co-panelists, Mr. Kiran Anandam Pillai, Mr. Manasi J, and Mr. Rajat Garg. On behalf of Tech Bharat, thanks a lot for the great panel. Thank you very much.